Thank you, Mr. Chairman, for the very kind introduction and very good morning, ladies and gentlemen. I would like to thank the Malaysian Thoracic Society for firstly considering and dedicating a topic dedicated to pregnancy, and for secondly, kindly inviting me to speak at this wonderful conference. I would like to sincerely apologize that I'm not there physically, ladies and gentlemen, but I'm truly honored to deliver this lecture today titled Obstructive Sleep Apnea in Pregnancy. Ladies and gentlemen, I've got no conflict and I've got no disclosure to declare for this talk. Now, what are our biggest challenges in managing pregnant ladies? Challenge number one. When it comes to pregnancy, when it comes to pregnant mothers, we suddenly stigmatize them. We tend to do less for pregnant mothers who actually need more in terms of cardiorespiratory symptoms and assessment. Number two, as physicians, we are often always uncomfortable managing pregnant mothers, be it medications, be it imaging, be it interventions. And thirdly, we often tend to blame pregnancy for physiological changes, although it may actually be a pathological condition. I believe these are the biggest challenges in managing pregnant mothers. With that, ladies and gentlemen, in the next 20 minutes, I've got 6 highlights. I would like to discuss about sleep disorders in pregnancy, the obesity pandemic in Malaysia, respiratory adaptations that all of us think we are experts in, how to screen, the challenges in screening and how to make a diagnosis, the paradigm shift in screening for obesity that I'm going to highlight today, and some steps moving forward. Now, ladies and gentlemen, there are significant respiratory adaptations in pregnancy. A pregnant mother is hypercoagulable. A pregnant mother has got an increase in cardiac output in the second trimester, but most maximum in the third phase of labor. She's got a modified immune response, which makes us more susceptible and more severe to infections. She's got some respiratory adaptations that make her more tachypnic with a reduction in her reserves. She's got congestion. She's got mucosal edema. She's got a reduction in patency. She's got a higher chance of sleep disorders and obstructive sleep apnea. It's going to be difficult to intubate a pregnant. Hence, sleep disorders are common. What are some of the common symptoms that a pregnant mother may complain? Increase in awakenings, insomnia, especially in the third trimester. Increase in total sleep in the first trimester, perhaps made worse by hyperemesis gravidarum. A decrease in the total sleep in the third trimester purely because of fetal kick chart and fetal movement. Decreased sleep efficiency. Decreased REM sleep, but increase in stage 1 REM sleep, but decrease in stage 3 and stage 4 non-REM sleep. Increase in wake time after sleep onset, and these are the sleep disorders in pregnancy. And ladies and gentlemen, we as physicians are also very familiar with some gestational syndromes. Gestational diabetes, we know. Gestational hypertension, we know. Gestational thyrotoxicosis, we know. Peripartum cardiomyopathy, we know. But do we know there's also a silent condition called gestational obstructive sleep apnea, which is made worse by the pregnancy, which is not benign and may have maternal and fetal implications. So yes, ladies and gentlemen, it is prevalent. It is an important condition. So sleep apnea can be divided into 2. Chronic sleep apnea, which you had pre-pregnancy, you can diagnose this in the first trimester. Second, people believe there's another gestational syndrome called gestational sleep apnea, which is never there in the first trimester. The pregnancy physiological changes makes it worse. It is not benign. It needs to be screened. It needs to be treated. And that is one of the important take-home messages of this lecture. Now, why does a pregnant mother has got a sleep disorder breathing? An important hormone is progesterone. So what does progesterone do? It causes rhinitis, it causes snoring, it makes your sleep disordered breathing worse. More importantly, it causes an increase in ventilatory drive. It causes respiratory alkalosis. It causes a change in the ventilatory pattern. Mechanically, the enlarging uterus displaces the diaphragm upwards. shortens the thorax, reduces your inspiratory reserve volume, changes the pressure, there's bronchial collapse, airflow limitation, and causes sleep disordered breathing, which is all exacerbated by pregnancy. What is the incidence, ladies and gentlemen? Now, various studies quote an incidence of 15 to 20%, but I, for one, believe that this is far underreported. It is far underdiagnosed. The true incidence remains higher, especially among obese women, women with comorbidities such as hypertension, such as preeclampsia, such as cardiac diseases. So I believe we do not know the true incidence, which is even more higher than 1 in 5 among pregnant mothers. So what are the questions I intend to answer? Should we screen pregnant mothers? Who to screen? How to screen? When to screen? First or second trimester? Is one test in the first trimester important? Or do we need to screen in the second trimester? All 5 questions I hope to answer in the next 15 minutes. These are some of the patients who now visit my clinic. Ladies and gentlemen, this is not an uncommon sight among women in the reproductive age group. We now have an obesity endemic in Southeast Asia, in Malaysia. I'm sure everyone knows that Malaysia is the most obese country in Southeast Asia, 44.4% incidence of obesity. Now, this important study looked into the incidence of obesity in Klang Valley. And this study showed that the incidence of obesity among pregnant mothers is 20% in Klang Valley. I believe that is going to continue to rise. And I believe this is true across the nation. This important study looked into the association between OSA and obesity. And there's a direct association where the more obese you are, the higher the incidence of OSA. And I believe this is also true for pregnant mothers. The fraternity has moved forward. There's now a dedicated guideline to talk about management of obesity in pregnancy. And this is from the Royal College. And the confidential inquiry of Malaysian maternal deaths in Malaysia also has got a dedicated guideline for how to manage obesity in pregnancy. What does this guideline say? It says if you're obese, if you're pregnant, screen for diabetes, screen for nutritional deficiencies, screen for hypothyroidism, screen for GDM, talk about thromboprophylaxis, give a low molecular weight heparin, which is cost more than 3, and you should have a VT risk assessment at booking, each admission, post-delivery, before she goes back home. She needs aspirin to prevent preeclampsia, also screen for depression and anxiety, which is universal. But this guideline, nor does the UK guideline ever talk about OSA. Ladies and gentlemen, it's time we develop guidelines about OSA in pregnancy. It's time we enforce that obesity is a significant risk factor for OSA. Unfortunately, these 2 guidelines do not talk about OSA, and that brings to the gist of my talk today. Now, why do we need to screen? What are the implications of OSA? Now, we've got a sleep disordered breathing. We've got intermittent hypoxia. This intermittent hypoxia causes oxidative stress and inflammation, and that causes vascular endothelial dysfunction, and that causes gestational diabetes, that causes hypertensive disorders in pregnancy, that causes preeclampsia, causes preterm labor, and causes IUGR. So it is the oxidative stress and inflammation. Let's take a look in a more detailed mechanism. So OSA causes hypoxia. Hypoxia causes increase in angiogenic factors, especially S-spleet and S-endoglin. It causes a reduction in your pro-angiogenic factors, namely vasculoendothelial growth factors and placental growth factors. And this imbalance causes endothelial dysfunction, and that causes preeclampsia. So OSA causes preeclampsia, namely because it causes endothelial dysfunction. So if you treat OSA, you can actually treat preeclampsia, not just aspirin, ladies and gentlemen. CPAP reduces incidence of preeclampsia in women who have got OSA. Appreciating that, this beautiful multi-centered randomized control trial study was just published 2 months ago in the respiratory research looked into treatment of OSA among high-risk women, and is there actually benefits? The answer is clear. The answer is yes. Even if you treat women with mild to moderate OSA in pregnancy, there's a significant reduction in the diastolic blood pressure by 0.5 millimeters mercury. There's a lower BP trajectory in pregnancy, a lower incidence of preeclampsia. So take-home message, multi-centered, randomized controlled trial study. Even if you treat mild to moderate OSA, you have a significant reduction in preeclampsia. Now, what is the treatment of choice? You can ask the woman to lie left backward. You can ask the woman to avoid a supine position. You can ask the woman to prop up. You can ask the woman to use oxygen, but it's not been proven to be beneficial. You can ask the woman to take less sedatives and less alcohol, but the treatment of choice to have an impact in pregnancy remains nasal CPAP. And that has been proven clearly to improve maternal and fetal outcomes. So we know how to screen. We know the impact. We know the benefits. How should we screen for OSA? Ladies and gentlemen, most of us love our questionnaires. You can use your Berlin questionnaire. You can use your Stop Bank questionnaire. You can use your Epworth Sleepless Scale. You can use your American Society of Anesthesiologists. But alas, ladies and gentlemen, none of these questionnaires have been validated in pregnancy. Neither is sensitive, nor it's specific. The recommendations now is not to use any of these questionnaires to screen for OSA because it is not sensitive and not specific. And various studies have shown that these questionnaires have got limited clinical value to screen for OSA. Now, smart people are looking into various algorithms. From questionnaire, they've included bicarbonate levels, perhaps a little bit more beneficial. But this wonderful study, apart from screening questionnaire, they added 4 parameters: the BMI of the mother, the age of the mother, the neck circumference of the mother, and the tongue enlargement. And they found that it is slightly more better effective in screening for ASA. They are on the right path, but we are still not there. So screening questionnaires are not recommended to be pregnant in pregnancy yet. So if you suspect, don't do a subjective diagnosis. You need an objective confirmation. And that remains the gold standard of PSG, or people talk about home sleep test. And this seems to be the most accurate way. You need to objectively diagnose and confirm with at least a home sleep test. Final fact, ladies and gentlemen, having appreciated the importance to screen, the impact, the diagnosis, the benefits, we as physicians managing pregnant mothers also need to know that the risk in pregnancy is dynamic. As the pregnancy advances, there's an increase in minute ventilation, there's an increase in oxygen consumption, there's a reduction in the residual volume. There's a change in the vital capacity. There's a change in total lung capacity. And this is even more prevalent as the pregnancy advances. Risk is dynamic in pregnancy. So we do a sleep study in the first trimester. If it's normal, it does not mean it will remain normal forever throughout the pregnancy. We perhaps have to assess at different landmarks as the pregnancy advances. And this beautiful paper showed that OSA also can be progressive in pregnancy. They looked into incidence of OSA among various gestations. If you have got no OSA in the first trimester, they relooked the same patients in the second and third trimester and realized that it is even more prevalent in the second trimester. So, ladies and gentlemen, take home message from this slide: risk is progressive. Patients with chronic OSA, you may diagnose them for the first time during the first trimester. But if you have gestational diabetes, or if you've got mild diabetes, you've got gestational OSA or mild OSA, you may have to repeat the sleep study in the second trimester because the disease is more prevalent as the pregnancy advances. So now, ladies and gentlemen, questionnaires do not work. Neck circumference, tongue seems to be a little bit more beneficial. But my suggestion to everyone, apart from being respiratory specific, let's be holistic in our pregnant mothers. Take a good obstetric history. If she's got chronic hypertension, if she's got obesity, if she's got preeclampsia in the previous pregnancy or current pregnancy, if she's got FGR in the previous pregnancy or current pregnancy, if she's got a previous preterm delivery, if she's got a previous stillbirth or adverse pregnancy outcomes, or if she's got any other risk deemed important or significant by an expert, especially a maternal fetal medicine specialist, I think she needs to be screened, because I think she will truly have a significant impact if you treat the OAC, if it is confirmed. So take a good medical history, combine that with an obstetric history. If you can combine both, I think you can increase your implications and impact of treating for OAC. So my take-home message, ladies and gentlemen, I think screening for OAC is complicated in pregnancy. I think we need to work together. The sleep medicine specialist, the maternal fetal medicine specialist, you need to objectively confirm, which remains the gold standard. Checklist is not validated, but take a respiratory history. Ask about previous adverse pregnancy outcomes. If she's got yes, previous pregnancy outcomes, this woman should be prioritized. She should be screened early. If normal, screen again in the second trimester. And treatment will have a significant positive impact with maternal and fetal outcomes. Take a good obstetric history. Now, how to manage bariatric surgery seems to be the way forward. We prefer restrictive than malabsorptive. Micronutrients should be corrected pre-pregnancy. The interval from bariatric surgery to pregnancy should be at least 12 months. Echo to exclude pulmonary hypertension. Vaccines, because a pregnant mother is more susceptible to infections. Antenatally, we need to work together as a team between a respiratory physician or a maternal medicine specialist and a sleep physician. We need to screen all women at risk, especially women with a previous adverse outcomes. She needs aspirin to prevent preeclampsia. She needs low molecular weight heparin to prevent thromboembolism. She needs an echo to screen for pulmonary hypertension. She needs the vaccines to be updated because she's got a higher risk of influenza and COVID. The recommendation now is to have a neutral weight gain in pregnancy. She needs fetal growth scans. She can develop preterm labor. She can develop preeclampsia. The CPAP needs to be titrated as the pregnancy advances because pregnancy is a dynamic risk. She needs to see an anesthetist by 34 to 36 weeks. When to deliver? 37 weeks. How to deliver? There are no contraindications for vaginal delivery. Such patients should ideally need to be monitored in the high dependency ward. With BMI of 50, she's got a 50% chance of having a cesarean section. 3 parameters which are not used in the labor ward: respiratory rate, ECG, and SpO2 should be made available for these patients. In the obstetric ward, in the high dependency ward, in the postnatal ward, early CSC, combined spinal epidural, will reduce the risk of her having an emergency unplanned general anesthesia. And we should avoid opioids use among obese mothers, especially women with OAC. And these are the management of OAC. Moving forward, ladies and gentlemen, what is new with regards to OAC in pregnancy? I think the current obstetric fraternity have strongly now advocate sleeping positions. A mother should sleep in the left lateral, or at least should go to bed in the left lateral. That significantly reduces the incidence of stillbirth, fetal growth restriction. Supine position of sleeping is no longer recommended, and that is evidence-based. Exercise, which has been a taboo, it's now highly recommended for all women, especially women who are obese. You should need at least 140 minutes of exercise per week, which equates to 20 minutes of exercise per day. It should be moderate in intensity, non-weight bearing exercise, such as walking, swimming, cycling, jogging. It's safe in pregnancy. Traditionally, we've been engrossed with weight gain. The IOM guidelines about weight gain in pregnancy is not validated. The current recommendations, if you're underweight, it's okay to gain more, up to 18 kilograms. If you're normal weight, it's okay to gain up to 15 kilograms. If you're class 1 obesity, you should not gain 10 to 15 kilograms, you should gain 5 kilograms. But if you're class 2, class 3 obesity, neutral weight in pregnancy or no weight gain in pregnancy is the recommendation. That is not associated with any adverse maternal or fetal outcomes. We should move away from the IOM guidelines. And this is the current evidence with regards to weight gain in pregnancy. Moving forward, ladies and gentlemen, every woman in the reproductive age group who's got a BMI of above 35 with metabolic disorders, a BMI above 40, we should talk about bariatric surgery. especially if she's got OSA, diabetic, or hypertension. The Royal College of Physicians also has gone one step further. They come up with a guideline in 2019 talking about acute medical conditions. So, a woman presents with breathlessness, sudden onset. Please don't say it is normal. A woman is got orthopnea, is unable to lie flat. That is never normal. A woman has got breathlessness with chest pain, breathlessness with tachycardia, breathlessness with tachypnea, or breathlessness with a fall in SpO2, she needs to be investigated. If she says she's breathless, please investigate. Do not say it is physiological. Do not say it is normal in pregnancy. In everyone managing pregnant mothers, please use pregnancy-specific values. A PCO2 is below 30 in pregnancy. If a PCO2 is 35, that is already high among pregnant mothers. The pH is between 7.4 to 7.47. And the bicarb levels in pregnancy is between 18 to 22. So please use pregnancy-specific values for all cases if you are managing pregnant mothers. Finally, one other simple test that you can do in your own clinic is a stress test. You can do a 6-minute walk test. It's very safe for all pregnant mothers, be it twins, be it mothers with cervical insufficiency. I think a test should be dynamic. A test after 6 minutes, take a look at the heart rate. If it goes above 120, take a look at the respiratory rate if she's tachypneic. Take a look at the pulse oximeter. If she drops below 94%, then she's got a cardiorespiratory event that needs to be assessed, especially pulmonary hypertension. So use 6-minute walk test. It's a simple test in your clinic. People are looking into the benefits of having CPAP, whether it reduces FGR. It's good to watch this space. It is yet to be published, but I believe the findings will truly be interesting, and it is now called the SAFER study. Moving forward, ladies and gentlemen, if it's going to be one message that I'm going to pass over to everyone, it's going to be one take-home message. Please remember this complicated jigsaw, where the woman is at the center of the jigsaw. We as physicians to treat every pregnant mother the same as a non-pregnant mother, unless there's a strong reason not to. Medications should not be withheld. Imaging is safe. Do not say it is physiological. Have a senior expert review. Work as a team. Do not stigmatize a pregnant mother. Treat her the same as a non-pregnant mother, especially with regards to any cardiorespiratory condition. Most importantly, I hope from this meeting, we as obstetricians, maternal fetal medicine specialists can now work together hand in hand with our respiratory physicians to diagnose 2 conditions, especially gestational obstructive sleep apnea, which is often underdiagnosed, underreported, but treatment improves outcomes. So my answer to the question I started this talk 20 minutes ago, should we screen for OSA among pregnant mothers? Yes, because screening and treatment improves outcome. Who to screen? Apart from woman who fulfills your questionnaire, ask about women with previous adverse pregnancy outcomes. You may have a significant impact if you treat her. When to screen? Risk is dynamic. If it's chronic OSA, screen in the first trimester. If you're thinking of gestational OSA, perhaps screening in the second trimester, you may be picking up more important patients. How best to screen? Questionnaires have got low sensitivity. The gold standard remains PSG. You can use a home sleep test. But what we need as a fraternity, we need better science, better evidence on how to screen. And I hope we can work together on this aspect, which has been neglected for many years. So take home message, ladies and gentlemen, the challenge in OSA not lies in the treatment. We know how to treat, but it lies on screening and making a diagnosis. We need to work together to screen more, to diagnose more. We can treat them better. I think we need to work on validated questionnaires. Perhaps it is time we have dedicated sleep pregnancy clinics within obstetric units, especially who see high-risk pregnancies. I believe we will be diagnosing, picking up, and making an important impact among pregnant mothers. Managing pregnant mothers, we should understand that the risk is dynamic. What is normal today may not be normal in 2 months' time. we should treat every pregnant mother the same, if not more than a non-pregnant mother. We should not stigmatize. Treatment of OSA improves maternal and fetal outcomes, and we should include pregnant mothers in OSA trials, especially with regards to how to screen. And that is the only way we're going to have evidence, because we have denied pregnant mothers who are vulnerable for many years. With that, thank you so much for your attention. I'll be more than happy to take any questions if you have. Ladies and gentlemen, OSA is significant. We should screen, we should diagnose, we should treat. Thank you so much for your attention.